Hello everyone, welcome back to Synapse. This is a channel that will keep us interconnected to talk about concepts, actual clinical experiences, expert opinions, and review of the current literature. And this is for the promotion of evidence-based practice. It has been an interesting week for me where I encountered some situations involving medical or healthcare ethics. This has inspired me to make this video and review the principles of medical ethics tonight. So without further ado, let's dive into it. Here is the case. So Dr. Smith is a hardworking doctor in a low-income community. His concerns for his patients, knowledge, and judgment are respected by his colleagues. One day, one of his patients unexpectedly died. He was called before the hospital quality assurance. So from this, he agreed that he had made mistakes in his care and incorporated the lesson of this case to his future practice. So in this case, we got to talk about the principle of beneficence. So this is the obligation of providers to help people in need. So although Dr. Smith treats his patients to the best of his ability, he does not always succeed. And the obligation is to take care for patients to the best of one's ability. So that's the principle of beneficence. Let's continue our discussion. Here's a case number 2. Mr. Reynolds is a good and compliant client in the outpatient department. He suffers from insomnia and Parkinson's disease. Her wife requests the doctor to order strong sleeping pills for him. The doctor declines the request due to concerns for falls. In this case, the patient is a very good patient, and unfortunately, he suffers insomnia and Parkinson's disease. And out of concern, the wife is requesting the doctor to prescribe sleeping pills for him so he can sleep. However, the doctor was on the dilemma if he's going to prescribe the medication because he's concerned that this is sleeping pills, although it will help the patient to go to sleep or to help with the problem of insomnia, but it increases his risk for falling. So in this case, let's talk about the principle of non-maleficence. Okay, that's a principle of non-maleficence. So this is the duty of healthcare providers to do no harm. So what we call do not harm. Okay, so we as healthcare providers, we are duty bound to do no harm to our clients or to our patients. Healthcare intervention has the capacity to do good or harm or both. So non-maleficence entangles with beneficence. So in this case, Mr. Reynolds could benefit from sedatives or for the use of sleeping pills, but it may cause more serious problems. So here we have to weigh the risk and benefits. If the risk outweighs the benefits, then it's not a good idea. But if the benefits outweighs the risks, most of the time, as long as it serves the best interest of the patient and the patient is agreeable, usually providers prescribe or give the interventions to patients. As we continue, here's case number 3. Mrs. White is a frail 90-year-old elderly. So she has a new diagnosis of colon cancer. She's asymptomatic, but looks like the cancer has already metastasized to the liver. So there are two choices that was recommended by the doctor. Number one would be transfusion, parenteral nutrition, and surgery followed by chemotherapy. The other recommendation was watchful waiting with palliative in hospice care when symptoms appear. So Mrs. White is terrified of hospitals and prefers to remain at home. So she chooses to live comfortable before she dies. She decided not to want chemotherapy and communicated her wishes to her physician. Ladies and gentlemen, in this case, we're going to talk about the principle of autonomy. So, the principle of autonomy describes the right of a person to choose and follow his or her own plan of life in action. So let me repeat that. This is the right of a person to choose and follow his or her own plan of life and action. So it adds another consideration to the interrelated principles of beneficence and nonmaleficence. So decision making by providers cannot be made solely by a risk benefit analysis. So let me repeat that. The decision making by providers cannot be made solely by a risk benefit analysis. So in here, patient's preferences is a critical addition to the equation. So after you're gonna weigh the risk and benefits for a recommended intervention, you have to factor in the patient's preferences, which is like what it's stated here in this slide. It is a critical addition to the equation. So always remember that. So let's continue. Continue our discussion on autonomy. So it's the desire of individuals to control their own destiny, have choices in life and freedom. The right of competent adult to consent or refuse treatment. So in this principle, um, when we have children or situations involving children or unable adults, uh, a parent, a guardian, or another family member, or a surrogate decision maker name in a legal document has the right to make the decision for this population, like the children or unable adults. So, for example, an adult who has dementia or unexpectedly run into a situation when he or she can no longer make decision for himself. So a parent, a guardian, or a family member or a surrogate decision maker named in a legal document can make that decision for this patient. All right, guys, I hope you are still enjoying our discussion. So here is a case number 4. Mr. Henry suffers chest pain and was taken to nearby ER within 5 minutes. He then underwent immediate heart surgery. So here's another one. Mr. Black experienced severe chest pain. He calls 911. Okay, waits 25 minutes for help to arrive, where he dies after suffering arrhythmia while waiting for a long time. So it appears that there are two situations in here. So Mr. Henry, when he experienced chest pain, he was taken to a nearby hospital or ED right away within 5 minutes, and he survived because he was able to receive an immediate heart surgery, while Mr. Black unfortunately waited for 25 minutes before help arrived, and then he dies because he had arrhythmia, which is very life-threatening condition. So the difference is that Mr. Henry is a rich man, while Mr. Black belonged to the poor population. Unfortunately, sometimes this happens in the real world, in our world. So now, in the situation that we just talked about, uh, here we're gonna talk about the principle of justice. Okay, the principle of justice. The concept of treating everyone in a fair manner. That is a description of justice. It's the concept of treating everyone in a fair manner. So, in this situation, like newer or more controversial and harder to define in medical ethics, people are treated justly when they receive what they deserve. Justice refers to universal rights to eat, to be afforded shelter, to have access to basic medical care, and to speak freely. Wow, I like this phrase. So, justice refers to a universal right to eat, to be afforded shelter, to have access to basic medical care, and to speak freely. So here comes the golden rule, to treat others as you would want others to treat you. So we always hear all the time. So we have to treat others as we would want others to treat us. However, we have this what we call distributive justice. So in here, who receives what amount of wealth, education, or of medical care? Unfortunately, with regards to distributive justice, there's no agreement exists on what formula for allocating benefits and cost to um, the general population, like what is fair allocation um, um, for the benefits or for the cost. Is the budget uh, goes for this population, for this situation, and etc. Okay, so there's no agreement that exists on what will be the exact or fair basis or criteria for allocation of benefits and costs. Boils down to the question, should each person get an equal share? Should those who work harder receive more? Or should the proper formula be to each according to ability to pay? Or as determined by free market? Or each according to need? In here, we have what we call the universal insurance. So, based on the concept that healthcare is a right and should be distributed according to need. So, this is actually the dominant political belief in developed countries. However, in the United States, there's an ongoing debate between healthcare as a privilege and healthcare as a right. So, um, we always talk about equal access to the system, equal access to medical care without financial barriers. If that would happen in the future, that would be the best case scenario in this country, in my opinion. Again, this is debatable. There are two sides of the argument. One believe that healthcare is a privilege, and the other side believe that no, it's a right. So it is political in nature, and it's debatable, or actually there's an ongoing debate right now in our country about the issue of distributive justice for medical care. So during the early stage of our recovery for the pandemic, um, there was issues or controversies, and I think it applies to the concept, or yeah, the situation we call it rationing. Okay, this is the limitation of medical care such that not all care expected to be beneficial is provided to all patients. So, not all patients will be able to uh, receive um, an intervention that is expected to be beneficial. So the limitation of resources is such that not all care expected to be beneficial is provided to all patients, and the distribution of these limited resources in a fair manner. So for example, we have this amount of ventilator, um, but we have more patients that needs the ventilator. Who would these patients should receive ventilator treatment? So would the patient be categorized as letter A, young and able, productive member of the society, or number two, a very frail elderly who is under 90s, something like that. So this is what we call rationing. Hi guys, so going further, let's understand better the meaning of rationing in medical care. So the limitation of resources going to healthcare sets that not all care expected to be beneficial is provided to all patients in the fair distribution of these limited resources. So in this slide, I just repeated and reiterated the meaning of rationing in the medical care. As we approach the conclusion of this talk, so I'd say that physicians, nurses, physical therapists, chiropractors, or anyone in the healthcare profession will continue to face individual patients' responsibilities, but will find it difficult to escape the obligation to balance the wishes of individual patients against the larger needs of society. To conclude our talk, so the principle of beneficence, non-maleficence, and autonomy uh, rule the bedside. Grave justices still take place on a daily basis, unfortunately, and healthcare policymakers should continue to address these injustices. That's all for tonight. If you have any comments or good suggestions or experience or anything that you want to contribute to this discussion about medical ethics that we encounter as healthcare professionals on a daily basis, please feel free to write them down in the comment section. So if you are new in this channel, to help my channel grow, please share, like, and subscribe. Thank you very much, and I appreciate you all.